นะครับเดี๋ยวงั้นขออนุญาตปิดพิธีเปิดเป็นทางการนะครับก่อนสักแป๊บหนึ่งนะครับแล้วก็เดี๋ยวจะได้เข้าในส่วนของการบรรยายกันครับโอเคครับสวัสดีครับโอเคขออนุญาตกล่าวสวัสดีอย่างเป็นทางการนะครับก็สวัสดีครับผมนายเอกพันธ์ผู้เงินครับเป็นผู้จัดการด้านอุปกรณ์ของบริษัทประภัสสร Engineering Supply นะครับก็วันนี้ได้เกียรติในส่วนของพิธีกรดำเนินรายการนะครับในส่วนของการอบรมงานประชุมในวันนี้นะครับก็ก่อนอื่นเลยก็ทางบริษัทเองก็ขอบคุณทุกท่านมากครับที่สนใจในหัวข้อนี้นะครับถึงแม้จะเป็นวันหยุดหรือเป็นวันเสาร์เองก็ยังสละเวลามาเพื่ออบรมทางเราก็ขอบคุณมากๆครับแล้วก็ยินดีมากๆทั้งในส่วนทั้งออนไซต์แล้วก็ผู้เข้าร่วมที่เป็นออนไลน์นะครับในส่วนของงานประชุมครั้งนี้ครับในหัวข้อ Pelvic Health Across the Lifespan นะครับก็จะเป็นให้ความรู้ในส่วนของ Women Health ครับซึ่งน่าจะเป็นเทรนด์ที่ทุกคนเองน่าจะสนใจณปัจจุบันมากขึ้นครับก็ทางการจัดงานครับก็ได้ในส่วนของบริษัทประภัสสรนะครับแล้วก็บริษัท V2U ครับที่ช่วยในการจัดงานนี้นะครับโครงการดีๆอย่างนี้ให้เกิดขึ้นนะครับขออนุญาตเล่าในส่วนของตัวสเกดูคร่าวๆของวันนี้กันครับจะได้เห็นภาพว่าวันนี้เราจะได้เรียนรู้อะไรบ้างแล้วก็ช่วงเวลาเป็นยังไงครับในช่วงเวลา 9 โมงครับเราจะมีการ introduction นะครับเล็กน้อยนะครับจากดร. Margaret นะครับแล้วก็ในส่วนของ lecture ในหัวข้อแรกจะเป็นในส่วนของ clinical condition ครับแล้วก็ในส่วนของ pelvic health นะครับ anatomy ต่างๆนะครับเราจะมีทำการเบรกกันเวลา 10 โมงถึง 10 โมง 40 10 โมง40โทษทีครับ 10 โมง 40 จนถึง 11 โมงจะเป็นช่วงเบรกนะครับหลัง 11 โมงนะครับมาเลคเชอร์ต่อจนถึงเวลาเที่ยงครึ่งครับเราจะพักกินเที่ยงกันนะครับตอนเที่ยงครึ่งจนถึงบ่ายโมงครึ่งนะครับทางออนไซต์เรามีเข้านะครับเตรียมไว้ให้แล้วนะครับถ้าทางออนไลน์ก็ดูแลตัวเองนะครับแล้วก็เดี๋ยวกลับมาเจอกันตอนบ่ายโมงครึ่งนะครับบ่ายโมงครึ่งครับเราจะเริ่มบรรยายนะครับในส่วนของเลคเชอร์และจะมีการ demonstration วันนี้เราจะมี lab ในส่วนของตัวการ demonstration การใช้เครื่องกระตุ้นไฟฟ้าในส่วนของ pelvic health นะครับแล้วก็ยังมีในส่วนของ lab ที่จะใช้ในส่วนของ ultrasound image จะมาดูกันว่าเป็นยังไงกันบ้างนะครับก็จะทำการเลคเชอร์และ lab นะครับจนถึงบ่าย 2:40 ครับจนถึงบ่าย 3นะครับแล้วก็ในช่วงหลังบ่าย 3นะครับก็จะทำการเลคเชอร์ต่อนะครับจนถึง 5 โมงเย็นเลยจะแจ้งว่าในส่วนของผู้เข้าร่วมนะครับทั้งออนไลน์และออนไซต์นะครับเวลาที่มีคำถามขออนุญาตเป็นหลังเซสชั่นนะครับก่อนช่วงเบรกนะครับถามในช่วงนั้นจะได้ไม่อินเทอร์รัปในส่วนของสปีกเกอร์นะครับคนที่อบรมในส่วนของทางออนไลน์นะครับก็พิมพ์เข้าใส่ช่องแชทไว้นะครับแล้วเดี๋ยวทางเราจะช่วยกรองนะครับแล้วก็ช่วยถามให้กับสปีกเกอร์นะครับในหลังเซสชันก่อนจะเบรกและพักทานข้าวนะครับโอเคน่าจะได้เวลานะครับไม่เป็นการเสียเวลาอย่างนั้นเดี๋ยวขออนุญาตเชิญครับคุณชนัทนะครับธนุวงศ์การค้าครับกรรมการผู้จัดการบริษัทประภัสสร Engineering Supply ครับกล่าวเปิดงานในวันนี้ครับขอบคุณครับ
สวัสดีนะครับก็ได้เจอกันอีกนะครับยังไงวันนี้เนี่ยก็ต้องขอบคุณนะครับทางสปีกเกอร์นะครับทั้งสองท่านของเราก็คือดร. Margaret Sherburn นะครับมาจากออสเตรเลียท่านเป็นคนที่มีประสบการณ์เกี่ยวกับเรื่องของ pelvic health มาอย่างยาวนานซึ่งเรามีโอกาสดีที่ได้เชิญดร. Margaret เนี่ยมาในประเทศไทยนะครับก็ขอบคุณบริษัท V2U นะครับโดยคุณดิเนชนะครับซึ่งแกก็จะเป็นโค้ชสปีกเกอร์ในวันนี้นะครับยังไงก็ขาดตกบกพร่องยังไงทางบริษัทก็ยินดีส่งคอมเมนต์เข้ามาได้นะครับยังไงขอบคุณมากนะครับ
โอเคครับขอบคุณนะครับคุณชนัทนะครับธนุวงศ์การค้าในการกล่าวเปิดครับโอเคครับอย่างนั้นได้เวลาแล้วแหละจะได้ไม่เสียเวลาเนื่องจากวันนี้หัวข้อเราเนื้อหาค่อนข้างเยอะมากหวังว่าทุกท่านจะได้รับประโยชน์นะครับในส่วนของหัวข้อโดยส่วนตัวก็ตื่นเต้นมากนะครับในส่วนของหัวข้อนี้อาจจะเป็นหัวข้อใหม่มากๆสำหรับการที่จะอบรมในหัวข้อนี้แต่ว่าในโลกปัจจุบันเองก็ค่อนข้างเปิดกว้างมากขึ้นในไทยเองก็น่าจะได้ใช้ความรู้ทางด้านนี้มากขึ้นนะครับในการอบรมอย่างนั้นก็ขออนุญาตเรียนเชิญนะครับในส่วนของวิทยากรนะครับดร. Margaret นะครับโอเค Margaret let's start
Thank you very much, Ben, for that kind introduction, and for this invitation to talk to Thai physiotherapists all around the country. I feel very honoured to be part of your day. Thank you very much for the invitation to speak to you all today, online and here in this room. Now, it is tiring to listen to English spoken all day. I will try to talk slowly so that your brains don't fatigue by 10 a.m. However, please interrupt me in the room if you feel that I am speaking too fast, you don't understand the Australian accent, or any other reason. My name, as you know, is Margaret Sherburn. I'm a specialist continence and women's health physiotherapist from Australia. Now, what does that mean? In Australia, the Australian Physiotherapy Association has a college of physiotherapy for physios to take on further education and take exams to become a specialist. So it's the same as, say, a doctor who might become a gynecologist or an orthopaedic surgeon. So there are not very many of us in Australia, but it is something that I think is very good from the point of view of the Australian physiotherapy profession. And I guess today I would like to inspire some people to do more study in this excellent field of physiotherapy. It's been a long time since I have treated a torn biceps or hamstrings or a sprained ankle, because this field is very different. And I'm going to illustrate that by starting today with a case study of a young woman called Kylie. Now, Kylie is a very Australian name. We have a very famous singer called Kylie Minogue, and about 30 years ago she was very famous, and there are so many girls in Australia with the name of Kylie, named after this famous singer. So this would be a typical patient coming to see, say, me in my practice. She comes to me and says, "I have a weak bladder." Well, that's very different to a sore shoulder or a headache or a cough. So you're sitting there thinking, a weak bladder, what does that mean? So I'm going to go through this case study thinking about what's the key information that you have to take away from her story. So she's been referred by a gynecologist. Good. Why is that good? Because it means she has been screened for any major problems, any major pathology. But she's been referred for bladder leakage. Now, does bladder leakage fit with a weak bladder? I don't know yet. She's 36 years old. She should be the peak of her health, and yet her bladder is not working properly. She's had 3 children. They are young. So you think, why is that important in my treatment of Kylie? So we think, is there a problem by having children? Did she have a caesarean section, or were they vaginal deliveries? She says, right now, I've got this weak bladder, and it's been that way since the birth of my last child, 2 years ago. Right, so you think something happened at that birth, made it different. So now we have to think of a link between childbirth and a weak bladder. We still don't have any answers, but we are clinically thinking about this problem. I ask about her health. Excellent. She's not ill. She's got a normal BMI, body mass index. It might be large for a Thai girl, but for Australia that's quite normal. She's had no history of surgery, particularly surgery in her pelvis. And all her births were vaginal deliveries. So something must have happened in that last delivery. We'll have to find out. So that will be part of my history taking. Here comes some more answers. She had a very large baby, over 4 kilos. That would have been very hard to push out. Oh, but it was very fast. So now we have to think of the structures within the pelvis, and we think of muscle, fascia, ligaments. Collagen is viscoelastic, isn't it? If you stretch collagen very fast, it doesn't stretch, it tears. We might have a problem here. Finally, I ask her about breastfeeding, because when you breastfeed for a long time, your hormone status is different. So she hasn't got back to a pre-pregnant state until she finishes breastfeeding. That's not to stop anybody from breastfeeding, but it just triggers in my mind that I wonder what she did during those 9 months. Did she go back to high-intensity exercise, for instance, before her ligaments were healed again? I'll ask her that later. I've gone through the key information. Key information is picking out the bits of her story that you're going to ask for further information. So, what do you think Kylie's main problem is? She's got we still don't know. It's a weak bladder, but she's had some sort of damage, you might say, in that last delivery of the baby. So we ask ourselves, do we need more information? Absolutely. This is just the beginning. So let's ask her some more questions, particularly about what she's doing with her body. Her work. She runs her own small store and works full-time with those 3 young children who she is lifting and carrying. When you run a small business, many of you might know as physiotherapists or as business people, you do a lot of lifting, carrying, moving. So she has been very active. Is that what we want to heal fascia and ligaments? Maybe not. Oh, and she does CrossFit. Do you have CrossFit in Thailand? It's a very energetic exercise program. I know it's in other parts of Asia, and it's certainly in America. She does it twice a week. So there's lots of pulling, pushing, lifting, running, box jumping. And she has small leaks when she runs or lifts heavy weights. That's interesting. So the leakage, now we know there's leakage. This weak bladder means that it's not holding what it should. She's a young, healthy woman. She should not have her bladder leaking. But it only leaks when she is overstressing the body. Here's another bit of information. She has to change her pad. It's that bad that a young woman like her is wearing a pad? This is not good. So then she says, well, I did exercise after each of my babies, but after the last one, everything felt different. I'll have to ask her what she meant by felt different. So again, I've told you the key information. Small leaks when she does effortful exercise. Plus she works. Plus she's got 3 young children at home. So she is putting a lot of strain on her body. Maybe too much strain for her pelvic organs to manage. So I'm not going to tell you yet what my diagnosis is or what her main problems are, but you can see now that her main problem, how she feels, it is leakage from her bladder. That's what she means by a weak bladder. So by the end of today, I am going to ask you to explain to Kylie the likely reasons for her leakage, and the role of pelvic floor muscle training. I'm going to use that PFMT, pelvic floor muscle training, during the day, and so you know now what I'm talking about. All right, so that will be all for that slide. Thank you. We'll go on to the next presentation. So keep Kylie in mind as we now talk about some of the clinical conditions that you will come across when you are a women's health physiotherapist or a pelvic health physiotherapist. And these are their names: incontinence, nocturia, pelvic organ prolapse. They are the ones that you will see most commonly. There are more, and I'm going to list them in this presentation. But because this is a one-day taster, you might say, of all that pelvic floor physios can do, I won't go through all of them. You can have the printout of the lecture as your reference and look at it when you come across a patient. So we'll look at incontinence first. Before we do, let's look at all the dysfunctions. This is your list. These are the patients you will see when you become a women's health physio. Or if you are teaching, these are the conditions you need to teach about. So they are categorised in 5 sections. Urinary, bladder dysfunction can be incontinence, urgency, which are both problems of the bladder not storing urine properly. It's a problem of leakage. The other is, what about having difficulty getting urine out? So some people, men and women, have difficulty actually urinating, getting the urine out of the bladder. The next section are things that happen in the vagina, and that's predominantly prolapse. Then there could be problems with the bowel system. We could have incontinence of bowel. We could have difficulty getting bowel motions out of the body. And that's different from constipation. Constipation is very hard stools, hard bowel motions, whereas getting the bowel motion out of the body could be because the person is holding their muscles too tight. Then you can have sexual dysfunctions. And for women, that's probably mostly painful sex, called dyspareunia, painful sex. And the bottom one, a section about pain. And the most common condition is one that might have no cause at all. It is chronic pelvic pain. Like some people have chronic back pain or chronic headaches. It's sometimes we're unable as physios to find a cause. So that's your list. Keep it in mind. We will only do 3 of those conditions today. So incontinence, what's the definition? It's the complaint of leakage, involuntary leakage. That means you have no control over it. It just happens. The other thing to notice, it's a complaint. You don't have to see a woman leak to get a diagnosis. She can tell you, I leak when I do my CrossFit exercises. That's enough. So it means that incontinence is a symptom, not a diagnosis, until somebody actually sees the leakage. It might be that they see a wet pad or a wet spot on the clothes. So it's like falls or headaches. It's a symptom. So I'm just going to quickly give you a list here of the different types of incontinence so that you know that all leakage is not the same. So stress incontinence. This doesn't mean emotional stress, I'm anxious or anything. This is physical stress. Like Kylie, she does strenuous exercise. It's the complaint of losing urine with physical exertion, sneezing or coughing. So it's a simple one. Someone does too much jumping, trampolining with their children, and they leak. The second one is urgency or urge incontinence. This is totally different. This is a neurological condition. This is when the nerves to the bladder are hyperactive. They are switched on and they are causing the muscle of the bladder wall to contract. And thirdly, you could have them both together. And sometimes this is the case. So you have a double incontinence to treat. Some other ones which will come into this are frequency. That means going to the toilet too much. Do you know anyone who does that? You go to the toilet before we leave home. Go to the toilet at the shopping centre. Go to the toilet as soon as you get home. That's not normal. And so that has a name, frequency in English. The next one, I've got a star against it because I'm going to talk about this separately. Nocturia is quite serious and it is a marker of poor health. It's getting up at night. So a 36-year-old Kylie shouldn't need to get up at night to go to the toilet from her bladder. She might get up to settle one of the children or whatever, but her bladder waking her, it shouldn't happen at a young age. But certainly as an older person, I'd say everybody gets up once at night if they're older. We've already talked about urgency, so I'll leave you the definition there. If you get urgency, frequency and nocturia all together, that is called overactive bladder. The bladder is showing all signs of neurological problems because they all mean that the nerves that supply the bladder are not acting normally. So here, what about getting the urine out? You go to the toilet, you sit on the toilet, and the first one is hesitancy. The urine just doesn't come out straight away. So there's a delay between sitting and beginning the flow. For some people, there is a slow stream. Urine should come out quite quickly. But for some people, it's just a very slow stream, and that's not normal. Another one is when the urine comes out, but it stops. And the person has to push to get the next bit out and push until the bladder empties. And then this is what they do to manage those problems. They sit on the toilet and strain to get the urine out. That's a problem. It is not normal. So there's a few slides of definitions. You don't have to remember them all, but to just have them there ready for when you have a patient. So what is normal? You'd like to know for yourself too, as well as your patients, I'm sure. So everybody's bladder holds between half a litre and for some larger men up to 1 litre. But we don't wait till we get that much in our bladder before we have the sensation in our brain to go to the toilet. We usually go to the toilet when our bladder is about half full. So that means we should toilet about 4 to 6 times in a day as a young adult, a bit more if you're an older adult, and only once at night, particularly when you're young. In fact, it would be better if you didn't go at all at night. So it's about half volume. This is what we tell paediatric patients, children who have problems, that your wee should be long, loud, uninterrupted. Don't let it stop. Get it all out and go. So that's, you can use other words for adults, but I like those words. Now, to have that much to remove from your body, it means you have to drink. Now, in Thailand, it's hot, so you probably drink more than this. But these are values for a cooler country like Australia. But it depends on body size, how hot the weather is outside, and whether you also eat lots of fruit, soups, salads, which are high water content foods. So that's very variable. If you're seeing a patient with bladder problems, you would work with that patient to work out what is the right amount of fluid intake so that they have those normal voiding habits. Now, we'll hear a lot about microbiomes now. Our gut has its microbiome, everything. So does the urine. It is not sterile, but it has, the bugs that are in your urine are different to mine, different to anybody else in the room. We have our own particular microbiome. So let's look at this stress incontinence. I'm already thinking that this is what Kylie has. It's a low closure pressure problem. So here down the bottom we have a diagram of a bladder with intra-abdominal pressure, that arrow coming down onto the top of the bladder. Look at the bottom though, the pressure comes straight down. We have an opening here. So the bladder's not closed properly and the muscle is sinking at the bottom. So this means when you add abdominal pressure, there is a leakage. So what's the pathophysiology? Oops, sorry. The urethral sphincter might be weak, and that's where the bladder joins the urethra here. The fascia that holds the bladder up to the bones might be weak or torn. The muscle at the bottom of the pelvis, called the levator ani, we'll do anatomy in the next presentation, might be weak. Why might it be weak? Well, there might be a neuropathy of the nerve that supplies that muscle. And if you go back to your undergraduate anatomy, you might have learnt about the pudendal nerve, S2, 3, 4. It comes the sacral spinal nerve. And in fact, there's a nice way of remembering it. S2, 3, 4 keeps we off the floor. So what's the main treatment for stress incontinence? Well, we've got to do something about these weak supports. And so, of course, what do we as physiotherapists use most? What's our target tissue? It's muscle. It's like hamstrings or biceps or any other muscle. We target a skeletal muscle that we can train to become stronger, faster acting, etc. So, you're thinking, Kylie, she did pelvic floor exercises after all her babies. This one felt different. So maybe we're going to start to look for pudendal nerve neuropathy or some fascial tear or muscle weakness. So already I hope you have some ideas in your mind about what you will do to help Kylie. So now we turn to the next problem or the next condition, urgency incontinence. And as I said, that's when the nerves that supply the bladder make the muscle of the wall of the bladder, and the name of that muscle is called detrusor. It's a new muscle you might never have heard of. You've heard of biceps, hamstrings, etc. This is a new muscle for you, detrusor. The detrusor is the muscle that forms the whole wall of the bladder. It's out of our control. It is not a voluntary muscle. It's like cardiac muscle or the muscle of our intestine wall. It's supplied by autonomic nerves. You think, well, I can't do much about that. That's like, that's a muscle that we can't do much about. But can we? Think about cardiac muscle. Think about the muscle of the heart. We've got the Olympic athletes on our TV all the time at the moment. Do you think their hearts are their cardiac muscle is as small as my cardiac muscle? No. What they've done is they've exercised and trained, and in their training of their body, they've actually enlarged the muscle of their heart. So let's not say we can't do anything about the bladder muscle, the detrusor muscle. Let's exercise the skeletal muscle that surrounds the bladder, and that by that method we train the bladder muscle, the detrusor muscle, to act more normally. So what's the pathophysiology? How does this occur? There might be a change to the sensory nerves supplying the muscle. So we might have to think about the nerves going all the way up to the brain. It might be because there's an infection inside the bladder. It might be that this bladder has been stretched so much and the muscles, because we know smooth muscle does not regenerate like skeletal muscle. Once it's torn, it's scarred. It doesn't form skeletal muscle fibres anymore. So you might lose some elasticity in the wall, and the bladder doesn't stretch like it does in my body, your body, every day. So you might have a stiff bladder. And of course, when we don't know, we say idiopathic, that maybe we'll never know what caused it. So that's urgency. And what's the treatment? Bladder training. And you'll notice that I've drawn a picture of the bladder here with all the nerve supply going up to the brain. So we're going to do some neurological training. So all the neurophysios in the room, there was a big crossover here between your world and my world. Now, I said Nocturia was different. Nocturia is a problem. It's a report... Oops, I'm sorry, what did I do then? It's the report of waking at night to void. It's a symptom, but we'll never know. We won't have a sign of it because it happens at night. The investigation is multifactorial, and that's the next slide. Many different factors come into it. And we've got what you do depends on what causes the nocturia. So it's more than just a storage problem. It's much more complex than what we've talked about before. Nocturia is an important symptom, very important. And here are the causes, this pie chart. Let's quickly go through them because you'll find that we can't intervene as physiotherapists in many of these. Let's start with around the... Oh, I've done it again. Sorry. The cardiovascular area, we could help there. If the patient has cardiovascular problems that are waking them up at night, we could probably help with prescribing some physical activity, some weight loss, some compression stockings, or lymph drainage if it's a fluid problem. For the brain, if it's caused by problems within the brain, it might be a sleep disease. So we can help as physios with weight loss and physical activity, but probably not with the other things, snoring devices or CPAP machines. What about the hormones? No, we can't help there. Kidney? Well, we can help with fluid intake, fluid timing. We'd need to work with the geriatrician, because this is mostly an old person's disease, about whether they are on diuretics or not. But if it's purely a bladder problem, of course, physiotherapy comes into that. Absolutely. And in fluid intake, well, we won't have much say in their sodium or their protein intakes, but we can at least help with fluid management, timing of their fluid, their amount of fluid that they are taking in. So just by looking at that chart, you can see that nocturia is a real problem. So if someone tells you, oh, I'm getting up 3 or 4 or 10 times every night, don't think that you can cure this on your own. This is not just a physiotherapy problem. You need to get a medical person in your team to help so this patient gets the proper care. Nocturia is a marker of poor health. So now we're going to go on to prolapse. Prolapse, by definition, just means something is dropping. It's a Latin word for falling down. So any organ in the pelvis can fall down and sit lower on the pelvic floor. Now, that's a sign. Sorry, I'm messing this up, aren't I? A sign is something that the patient feels, sense, and you can see. So they will say, I feel a lump in my vagina when I am washing myself. Or at the end of the day, I feel a heaviness. But it's not a problem unless they say they've got symptoms with it. Oh, I can't run anymore. I can't go to the gym anymore. They feel they are changing their quality of life. They are changing their lifestyle because of this falling down, this lump, this heaviness. They may say, I don't feel I can have sex anymore. So that means their relationship with their partner is being altered. And when they get symptoms, it means that it's at the level of the hymen, which is the lower end of the woman's vagina. And that's where the nerve supply changes from autonomic nerves in the pelvis to somatic nerves in the body wall. So that's why they feel it. It's a change of nerve supply at that level. So what are the signs and the diagnosis? I'm going to whiz through these because this is reference material. You can look at this later. How we work out what's wrong is that we image the patient. I've got some good MRIs to show you in a moment. We make a diagnosis by correlating symptoms, signs, and any investigations. And the most common prolapse is the anterior compartment. In the bladder, what am I saying? In the pelvis, there are three systems, aren't there? There's the urinary system, the genital system, and the bowel system. Three totally different systems that all come together in the pelvis. So the bladder is at the front. So the anterior compartment of the bladder tells us that the bladder is the most common organ to fall down, sit lower in the pelvis. Now, these are the names of all the prolapses. You'll notice that they all end in ocele, ocele, ocele. Cysto means bladder. Urethra is the urethra. Small bowel, rectum. So you can look at those definitions later. But anything with a cele at the end means a prolapse, a falling down. However, you could have a rectal prolapse, which is the prolapse of the, I forgot a word there, the rectal mucosa, the inside lining of the rectum. You might have to write that word in. And the uterine prolapse is the descent of the uterus, of course. So let's look at this. We seem to have lost something there. Okay. So I've lost all the pictures in this. There was supposed to be some diagrams here. You have them in your notes anyway. I presume they're in your notes, the pictures of the prolapses. Yes, they're not on that screen, are they? No. Do you know what? You'll just have to look at them in your printouts. I'm sorry. But you can see in the diagrams, the first diagram shows how the bladder can fall down. On the next slide, you can see the bowel coming down, a loop of the bowel falling to the entrance of the vagina. And on the third picture, there is drawings of the uterus, and it shows how far down the vagina the uterus can fall, and the uterus can actually come right out of the pelvis. That's a very, very severe prolapse. And the MRIs, you've got the MRIs of this woman lying down and then standing up and then with a strain. So look at the three images. I'll take you through them if you are looking at your notes. The first one, you can see a line, a straight white line drawn from the lower portion of the pubic bone across to the sacrum. There is a white area just above that line. That's the bladder. It's filled with dye so that it shows up white on the screen. When the woman stands up, that's the middle picture, you can see that white bladder sits below the line. And then when she strains, it sits even lower. So it's a really good picture for you to go and look at again at another time to show, if someone has a prolapse, even standing up could be a problem. But if they have to strain, like Kylie at CrossFit or at lifting in her shop, she could be also causing a worse prolapse. So I won't stay any longer on those because we don't have the pictures on the screen. I'm sorry about that. Now, there are international measurements of how far prolapses go down, and they go to stage 4. Stage 4 is really only for the uterus when it comes right out of the body. For physiotherapists, we would see mostly patients who have stage 2 or stage 3, because patients themselves don't come to see a physiotherapist until it's a bother. You ask, out of 10, how much does this bother you? And anything above about a 5 out of 10, you know that it's interfering with her life. So it looks like we've lost the next one too. Something's happened between 8:30 when I loaded this up to now. Are we going to... Can we wait? Just be patient for a moment. The excellent tech team are going to see what they can do about this. Does anybody in the room have any questions?
I have one question. At slide number 12, what does TANGO stand for? On the slide number 12, what does TANGO stand for?
Tango, this screening form Tango is, I have forgotten what the acronym stands for, but you can Google it, and it's a screening form for Nocturia. And so it's a very good screening tool. One page, Google it, and it covers all the areas that are in the pie chart. But I'm sorry, I can't remember what the acronym is. Yeah, Google. Do you want my computer? We'll pardon? Right. So now everybody online, thank you for your patience, can see what we mean by prolapse. So here we can see the bladder is falling into the vagina and it's bringing the uterus down, but the bowel, the rectum, is in its normal place. Let's go to the next one. Now you can see the bladder in its normal place, but the loop of the bowel projecting down out of the line of the body. And also you can see the uterus does come down a little as well. And this is the picture where it shows uterus normal and then could slide anywhere down the vagina until it comes out. That's called a procedentia. And here we have the MRIs. Hooray! These are my favourites, you see. So this is a lady lying down. This is the pubic bone. This is the sacrum and coccyx. And the radiologist has drawn a line from pubic bone to coccyx. This is the bladder filled with a dye, and this is the urethra. Here's the uterus. You can see it's already tipped back, and this is the vagina coming down, and a little bit of bowel you can see at the back there. What's interesting is that because the uterus is not sitting on top of the bladder where it should, all of the small intestines are sitting lower on the bladder. So that every time she even stands up, they are going to be causing problems within the pelvis. So yes, here's the same woman standing up. And now here's this line coccyx to pubis. Here is the bladder really squashed. And here is the urethra round the corner. So she might have a lot of difficulty getting wee out of her bladder. The uterus is tipped almost vertical, up and down, and here's the vagina really twisted around and around and around, and all of this is intestines. Now we ask the woman to strain, to bear down, like this. And look what happens. The bladder goes way, way down. The urethra is really kinked. And the uterus is very upright and the vagina is very curved. So, when a person has a prolapse, she already has a lot of fascial damage that causes the prolapse to come down. So let's move on. This is a reference slide. And this is where we were before. As physios, we see stage 2 and 3 mostly. This is an interesting slide. Prolapse seems awful, doesn't it? No, I hope all you women in the audience and online are sitting there thinking, oh no, let's not this happen to me. But in reality, in this population study, most of the prolapses in the world are stage 1 and stage 2, and hardly any become severe. So a lot of women live with prolapse, they don't even know they have it. But what are the risk factors? Kylie hasn't mentioned anything about prolapse, but I would be making some comments about the possibility of prolapse because she is doing so much exercise. So what are the risk factors? Increasing age, the number of children you have, her waist circumference. She needs to keep her weight in check. Can occur any time of life, but because of the fact that the whole world is becoming more obese, there is more food available for everybody in the world at the moment, it might become a condition that physios see more and more. So these are the other risk factors: heavy lifting, constipation and straining on the toilet, chronic pulmonary disease. So I hope the pulmonary physios online and in the room are thinking, do I ever ask my chronic cough patients, my asthmatics, my cystic fibrosis patients, anything about their incontinence? It might be a good idea to ask them. And of course, the weak pelvic floor muscles. Hooray, something physios can really work on. Now, parity, that word in English means the number of children you have. So this diagram, number of children on the bottom, 1, 2, 3, 4 or more, and the risk, relative risk of having incontinence or prolapse. What it tells us that the more children you have, the more risk you have for both incontinence and prolapse. So Kylie has had 3 children. She's coming to you because she's got incontinence. But at 3 children, yes, she's got more than 2.5 times the risk of having incontinence, but about 9 times the risk of having prolapse later in life. So I think that I will talk to Kylie about prolapse as well as her leakage, her weak bladder. We need to ask ourselves, is the problem just in the pelvic floor muscles? Sure, there's plenty of evidence to show there is an association, but not a cause. It's been shown in research, physio research, that women with prolapse, pelvic organ prolapse, generated about 43% less force than someone without prolapse. So their pelvic floor muscles in general are weaker. Another physio project looked at, was it strength the problem or was it coordination? Do most women have a right amount of pelvic floor strength, but they don't use their muscle fast enough, or they don't hold long enough? So is it coordination with their other actions? So I should look at Kylie's exercise form, the way she does her exercise. Now, Kylie mentioned that after her last birth, her exercises felt different. So maybe she has what is known as an avulsion. Now, avulsion, we all know from hamstrings tears or any other tear in the body, it's a tear of the muscle off the bone. Could the pelvic floor muscle have been torn during childbirth? We'll talk about that later. But for the moment, I wanted to show you right now this slide of how it's a good diagram to explain to patients how everything is coordinated in the pelvis. So, in these diagrams, the boat is the pelvic organs. So here we have a boat at a dock. Here's the wharf, here's the sea, and here's the boat. Pelvic organs, the ropes tying the boat up to the dock, and the water is the support underneath of the pelvic floor muscles. If we take away the pelvic floor muscles, they are weak. What happens over time is that all the strain that's on the ropes get frayed, they get weak, they stretch a bit, and the boat is at risk of falling down into the pelvis. So you can get pictures of that online. Once again, Google or any other search, and you can find this picture. But have it on your desk so that the patients can understand why you are so concerned about the muscles. So here I'm just going through what you would do as a physio. You'll take a patient history, you'll look at the symptoms, you'll do some questionnaires. The POP-SS is Pelvic Organ Prolapse Symptom Score, again, found online. And there's the Australian pelvic floor questionnaire you can find online as well. To find out what signs the patient has, how far has the prolapse dropped, you'll need to do a pelvic floor examination. We're not going to do this today. That's a whole step in further up. You want to find out the pelvic floor muscle function and where the organs are sitting in the pelvis. But if you don't ever do vaginal examinations, you can use some imaging, particularly ultrasound, and we'll do some of that this afternoon. You can read this at your leisure, but it's an algorithm that's, again, available. And here comes physio at the bottom. Observation, lifestyle interventions, pelvic floor muscle training. So when a woman has a prolapse, we are not the primary clinician. We come in at the end, okay? And what are we going to do? We're going to give education about preventing. We might do nothing. We might just say, we'll just wait and see how it goes. It's not, the bother out of 10 is maybe 4 out of 10. Let's just sit there. It's not dangerous. It's not like cancer or anything. It's a physical change in the woman's body. So our conservative management will be modifying lifestyle. We are going to try to reduce the pressure on the body. We'll do pelvic floor exercises, and we might put a support device in the vagina. That's called a pessary. Finally, surgery. And that's the end of that first session. So stand up, move around at home, stretch yourself, and take a moment's break before we start into some anatomy. Let's look at the detail of the anatomy. The tech team will get that up. You can exit that one and get the anatomy one up next. Okay, I want to see a bit of stretching in the room. Stand up, everyone, and circle your shoulders. Come on, jiggle that. We're physios. Let's do some physical work. Stretch your knees up, come on. Circle your pelvis, swing your arms. Even a little run on the spot. One question? Yes.
ครับโอเคครับพอดีมี1คำถามนะครับจากออนไลน์นะครับโอเคครับ one question from online why chronic pulmonary disease is one the least factor of POP
Why is COPD a risk factor for incontinence? I'm going to explain that in more detail in this next presentation when we look at the biomechanics of coughing and lifting, etc. So thank you for that question online. Could you be patient and I'll answer it before morning tea. All right, are we ready to go? Do you feel refreshed, stretched? Okay, how good are you at your anatomy? Let's find out. Because if I'm going to explain to Kylie, I need to know my anatomy, my pathology really well. This is the pelvis with nothing in it except the floor. So the floor of the pelvis, so here we have, looking down the sacrum, the alar of the sacrum, the sacroiliac joints, pubic bones, pubic symphysis at the front. When we look down into the pelvis, we see muscles at the floor. Now, the pelvic floor muscles are a group of muscles, not a single muscle. So the name of the pelvic floor muscle anatomically is called levator ani. It lifts, levator, lift, the anus or the ani. but there are other muscles as well. So let's look at them in detail. Here we've got the pelvis cut in half. At the front, here is the pubic bone. Here is the sacrum coming down to the coccyx. Here is the sacral foramen. And we have a favourite muscle for the musculoskeletal physios, the piriformis. On the pelvic side walls, we have the muscle obturator internus that turns out of the pelvis to become a hip muscle. But inside the pelvis, it forms the origin, a fascial origin of the levator ani. And here's the levator ani, the floor of the pelvis. But it has holes in it, doesn't it? Because we have tubes that come out of our pelvis. Firstly, the urethra from the bladder. In the middle, we have the vagina in women. And then at the back, we have the rectum coming down to the anus. So you can see that the pelvic floor is a floor, but it has, it has holes in it. Now let's look from the underneath side. We tip the pelvis up and look up from the legs up into the pelvis. We see here's the pubic bone, pubic symphysis. We have the woman's clitoris. We have the uterus. We have the vagina. And we have the anus. So they're all in the central line. We now see that we have another layer of muscle closer to the skin. They are the superficial pelvic floor muscles, the ones just under the skin. And then the deeper pelvic floor muscles are the ones we saw in the previous slide. And they are made up of, I'm not going to go into the names in particular, but they, if you want to know them, they are puborectalis and iliococcygeus, and they form the levator ani muscle. So, let's see. Right, looks like we're going to have a few problems again. So this was another slide of the pelvis. What I did want to show you, is this on your printout? Okay, so this is looking front on at the pelvis. Yeah, and what I wanted you to notice was that at the bottom of the vagina, that's where we get a change of neurology from somatic nerves, the pudendal nerve, and above the blue line you might be able to see on your slide, we have autonomic nerves, the sympathetic and parasympathetic nerve supply. Oh, it hasn't, not even on my, yeah, it looks like we might have this problem all day. I'll make sure, I might use my computer after lunch. Okay, well, okay, so let's put the organs on top of the pelvic floor now. So now we have the pubic bone at the front. Oh, sorry, where is it? This is the superior pubic ramus and the inferior pubic ramus. And we have the coccyx sacrum and coccyx at the back. This is the pelvic floor muscle cut here. In the front, we have the bladder, just behind the pubic bone. Behind that, we have the uterus, usually sitting on top of the bladder, and the vagina coming down. And here we have the rectum and the anus going backwards into the pelvic floor. And these muscles here are those superficial muscles you saw in the previous drawing. So you can see that the pelvic floor is considered to cover all three compartments in the pelvis. We've got the urinary system, we've got the genital system, and we've got the gut. the digestive system at the back. Here's another view of the same thing, but what I'm showing you here more is the fascial slings and the ligaments. Go back to that boat sitting in the harbour, the ropes that were holding the boat to the bones of the pelvis. Here is a more anatomical picture of them. So we've got bladder, uterus and rectum, and here we have slings, ligaments going up to the bones. We have ligaments going to the side walls. So everything is really well held in place. Now, as physios, we only deal with what we call level 3 supports. Surgeons will repair supports that are torn higher up in the pelvis. But as physios, all we're going to be dealing with is the lower third of the vagina, because that's where the pelvic floor muscles are, and the urethra and the anal canal, because of the fact that that's where skeletal muscle is. We are only going to get to the ligaments via our strengthening of the skeletal muscle. So let's look at the bladder in particular, because I mentioned the word sphincters in the previous slide. This picture is of the lower portion of the bladder and of the urethra. Here are the pelvic floor muscles coming in either side, and these are the superficial muscles just under the skin. These are the folds of the labia. So we have muscles, oops-a-daisy, we have muscles that circle the neck of the bladder, and that's, we don't have much control over that. That is smooth muscle. What we do have control over is the skeletal muscle that forms all along the side of the urethra and actually forms rings around the middle of the urethra. Now, have you ever thought, can I tighten the muscles around my urethra? I would say no, because we don't. Even me, as an experienced pelvic health physio, if I want to tighten the muscles around my urethra to stop urine coming out, I tighten my pelvic floor muscles. Our brain doesn't have enough differentiation between urethra and the whole of the pelvic floor. So I'm telling you this so you know anatomically, but in reality, I don't think you'll be asking patients to actually tighten just those muscles. It will happen because of the excellent way you teach the patient how to do their exercises. And here is a diagram to show you those circular muscles around the middle of the urethra, and then those superficial muscles that go back to the wall. We also have to think about the urethra itself. The urethra is very complicated. It's such a narrow little tube in our body, but it has layer and layer and layer of different types of tissue. And nature has provided us with this really thick-walled tube so that urine does not fall out when we don't want it to. One of the difficulties of becoming older is that the innermost layer is just under the mucosa. It's a vascular plexus, veins and small capillaries that provide a nice cushion for the urethra because it's closed for most of the day. When you think about it, you go to the toilet 4 to 6 times a day. That may take you 5 minutes. So your urethra has to be closed for 23 hours and 55 minutes maybe, or 50 minutes in any one day. So it has to have a really good closing mechanism that does not fatigue. And one of the ways of doing that is to have lots of blood vessels just under the mucosa so that they provide that cushioning. Now, here's the deal. when you become older after menopause, all these tissues that rely on estrogen start to thin. And so particularly these blood vessels under the mucosa are not as dense. And so the closure of the urethra does become less tightly closed later on in life. Doesn't matter for Kylie, but we need to warn her about that later in life. The neurology. Don't you sometimes think, oh yes, one of these diagrams. I remember these from when I was a student. So let's look at this. Here we have the pelvis, pubic bone, sacrum. We have the bladder sitting behind the pubic bone. The tweezers have pulled the uterus out of the way, and here is the rectum. Behind all that is a huge plexus called the hypergastric plexus of the autonomic nerves, the sympathetic and parasympathetic supply. The sympathetic nerves here's the sympathetic ganglion chain up the spine, up to L1 and 2. So our supply to the bladder is from, well, you see the circle at the bottom there, I'm starting at the bottom. We've got this sympathetic supply and parasympathetic supply forming plexuses in the bladder. We have a somatic nerve, the pudendal nerve, coming across the bottom from S2, 3, 4. We have nerves coming down from L1, 2, the sympathetic supply, coming down the ganglion chain, down the vertebrae, and then forming this hypergastric plexus. And we have S2, 3, 4. Oops, where's it? Where did it not work? Oh, right. It's the hypergastric plexus in the green circle. And I missed out on the parasympathetic nerves, but they are coming out from S2, 3, 4. So here is the 4 levels of control of our urinary system that we have. We have somatic innervation, pudendal nerve. We have autonomic innervation, sympathetic via the hypergastric nerves, and parasympathetic. Then we send all those messages up to the brain, to our primitive brain at the pons, and then we have our voluntary part up in the frontal cortex. So we decide when we go to the toilet. We decide when not to go to the toilet. That toilet's too dirty, too noisy. I'll wait till I get home. So there is a decision-making part of our brain when it comes to going to the toilet. It's not all autonomic. And that's where we play a part in bladder training. We use cognition. This is just for your information. I'm not going to spend time, except to say that the pons is very close to the emotional motor system of our body in the hypothalamus. And that makes us take care of where we urinate. As I said, a clean toilet, a private toilet. We don't think, oh, I need to go to the toilet and wee in a garden or anything like that. So there is an emotional side to bladder as well as a physical side to it. That's just where in the cortex I'm talking about where in the cortex the neural signals come from. What I wanted to point out mostly in this slide is that the motor cortex we're talking about the different parts of the cortex are involved in our urination, but the motor cortex is not. So a lot of neurologists have asked physios, why do you do pelvic floor muscle training? Because that's not part of the normal urinating reflex cycle. It's really the subcortical areas that are involved in normal voiding, and yet we as physios are training part of the motor cortex for voluntary action. I have no answer to that. You're going to have to the neurologists are going to have to work with people all around the world to answer that question. It is not answered yet. Finally, we're going down to the perineum. This is all somatic nerves, but if you are dealing with patients who have urinary system symptoms or prolapse symptoms, you have to know your anatomy of the perineum. So when you are doing a physical examination, you see the adductor longus muscles coming inside. Here we have the buttocks, the glute max. We have the anal opening. We have a section of tissue here with a dense mass of fascia called the perineal body. We have the labia, which are open in this diagram, but normally they sit closed together. And inside the labia, you have the vaginal opening, the urethral opening. And at the front, just behind the pubic bone, we have the clitoris with the hood over the clitoris. So that is your surface anatomy. And if you are going to then examine the pelvic floor muscles, remember they are deep to this. But we have the superficial muscles that are just under the skin, and then the deeper muscles. So I, as a trained physio, will do an examination, an internal examination of the pelvic floor by going into the vagina and asking the patient to do their pelvic floor muscle contractions so I can feel. Now, we'll go on to this one, the pathway of the pudendal nerve. Well, that slide didn't come up, but it will be on your printout. What I want you to see from this empty slide here is going across the perineum, the pudendal nerve branches out like a tree. It's one of the most densely innervated parts of our body. That pudendal nerve has branches that go up to the front of the pelvic floor and back to the anus. This is excellent because it gives us a very good area that's well innervated with sensory nerves. So the patient has a pretty good idea of where they need to work when you give them specific instructions. There is a downside to that, of course. If anybody has any damage to the area, the pain that is experienced by the woman is probably disproportionate to the actual physical tissue damage. So pain is a very, very deep and pervasive symptom, and it's because of the dense nerve supply of the pudendal nerve. So do remember that when a patient comes to you with pelvic pain or pain in the perineum, that you might think, oh, this is just terrible. Be calm and understand your anatomy so that you can guide the woman and help her with some pain management. Okay, so this funny little diagram tells you what happens in the normal cycle when about voiding, in the micturition cycle. On the y-axis, we have the pressure that's provided by the muscle of the bladder, the detrusor pressure. On the x-axis, we have the bladder volume increasing up to 400 mils. So let's follow this around. Follow the green arrows. You start with an empty bladder. It fills to 200 mils. Oh, I think my bladder is filling. But look, the pressure is staying low. It gets to 400 mils and you decide you're going to the toilet. But you see the pressure is still very low. You undress, ready to go to the toilet. Your detrusor contracts, woo, up there. It contracts suddenly and it stays contracted, forcing the urine out of the bladder, and then it stops contracting, pressure decreases, and back to zero. So this is interesting. Thinking of length-tension relationship of muscles, could a biceps do this or a hamstrings do this? Could it maintain contraction across a long shortening? So the detrusor muscle can contract and contract even though the fibres are getting shorter and shorter and still maintain its strength. It does not weaken as the muscle gets shorter and shorter, as the bladder shrinks as the urine goes out of it. It's a pretty exciting muscle. I like it because it keeps contracting all the way. If a patient says, "Oh, I have to stop and start my urine flow," you better remember that that's wrong. The contraction should stay on. It shouldn't stop, start, stop, start, stop, start. It should stay strong all the way. Here's a little animation to describe all I've said. So we have a full bladder, or the bladder, is filling. We've got our levator ani tight, and our sphincter muscles are tight. We get a stretch from filling, so the detrusor is relaxed because we're not going to the toilet, but the sphincters are contracted. You've got a desire to void, it goes up to the brain, but you decide, it's not time to go. So your muscles contract and you sit here and listen to this lecture because you don't want to miss a word. But now, the bladder's got really full. So you've got this stretch from the filling. You have a desire to void. But now you decide to go to the toilet, you go to the room, you take your clothes down, and now the detrusor muscle contracts, the sphincters relax, and the pelvic floor muscles relax, and you void. Okay, so it's complicated, isn't it? It goes right from the brain to the muscles. Now, I have spent the last half hour, or 25 minutes, talking to you about anatomy. But how are you going to explain this to your patient? Kylie is coming with a weak bladder, and you have decided, because she leaks when she does exercise, when she jumps, that she probably has stress incontinence. How are you going to explain the link between her weak bladder and you wanting to do pelvic floor exercises? So you have all this knowledge in the back of your head, but you might tell her something like this. For continence, for not leaking, we need the bladder muscle to be stable. You need to have muscles around the urethra acting as a sphincter, a closure. You need a floor that holds everything in place. You need a brain that recognises that you need to go to the toilet, how to go to the toilet, what a toilet is. And you need neural pathways between the bladder, the pelvic floor, and the brain. So where should a physio target their treatment? Of course, it's muscle, isn't it? So you can explain it to the patient like that. As a physio, my target tissue is muscle, and this is how we'll work it. What will you want to see if you are doing, say, an ultrasound image of the pelvic floor? You will want the muscle to tighten around the sphincters, you'll want it to lift, and you'll want it to go forward, particularly because you want to tighten around the urethra. So you're going to ask Kylie, or any patient, to make sure they feel like they are tightening enough to close their urethra. You'll want to feel or see an upward and forward movement of the pelvic floor muscles. And then if you ask the patient to do another activity like cough, that you don't get a downward pressure. Now, we're going from anatomy and neurology to biomechanics. And I think you will know all of this. I'm going to skip through this quite quickly because this is all stuff you would have known in your undergraduate courses. The pelvic floor is part of the core muscles of our body. The core muscles being our diaphragm, our abdominal muscles, our pelvic floor, and our back muscles. So we have a sealed capsule. Then the pelvic floor forms the base of that capsule. Is there a relationship between all of these muscles? Well, yes, we know that. And all of them, we know, have both a postural role and a dynamic role. And we also know that if there is an increase in the dynamic requirements, then the postural role is decreased. So I'm giving a couple of examples here at the bottom of the slide for people who are not pelvic floor physios. Let's look at the cardiopulmonary situation. If someone has a demand for their respiratory muscles, their diaphragm, say they are running or they are a COPD patient and they cough a lot, or if you have, then look at the musculoskeletal ones, if you have back pain and you have muscle inhibition, then you are going to have have to make a compromise in how the core muscles are used. So, of course, we use sneezing as our best example. And I'm going to get you all to stand up and do an exercise. At home, stand up too, please. Everybody in the room, please stand up, including people around. I want you to stand normally. Don't be stiff or anything. And I want you all, I want to look at somebody else in the room as you're doing this exercise. They're going to be looking at you and you're going to be looking at them. Please, everybody, in a moment, sneeze. I'll say 1, 2, 3. Then you're all going to sneeze and look at somebody else in the room. Everybody, 1, 2, 3. Achoo! Okay, what did you notice? What did you notice about the room in terms of posture, movement? You may all sit down. That was the exercise. Dinesh, did you see anything? Everybody moved, didn't? None of you, not anybody, even the IT people. You all went, achoo. You lost your postural stability. Okay, so please understand then that if anybody is coughing or sneezing or has back pain or has incontinence, if something is disrupting this lovely synergy between all of the muscles of the trunk, there could be a problem. Okay, so I got you to do sneezing and everybody, absolutely everybody, including me, lost their posture. Now, there's been lots and lots of research about this. So we know from lots of all physiotherapy research, aren't we wonderful, that the pelvic floor muscles contract synergistically with the abdominal muscles, particularly the lower third. Take note, all you musculoskeletal physios, when you ask, or Pilates instructors, when you ask the patient to pull in their belly button, that's the middle part of transversus abdominis. In pelvic floor work, we don't want that because that tightens up the thoracolumbar fascia at the back. That's really good for back pain patients, but not so good for pelvic patients. So those in the room might be able to see me. For pelvic patients, tighten the lower third of the abdominal muscles when you do a pelvic floor contraction. This synergy, though, is disrupted in patients with pelvic floor dysfunction. Yes, and the maximal contraction recruits all the abdominal muscles. Just keep note of that. So when you are deciding on the dosage of some exercises, that you understand that you're not doing isolated muscle contraction. You need at some stage of your rehab to put this muscle into the core, into the woman's full-on daily life. And do note that the pelvic floor muscles are more effective when the lumbar curve is normal. So if you're teaching someone to do a pelvic floor contraction in sitting, you do not want them slumped. They should be sitting tall. All right, so here we have a physiotherapist in a typical physiotherapy department with a cystic fibrosis child doing jumping on a mini tramp. Oops, I've gone one too far. I've given you the answer already. I have ticked the picture on the left. I've put a don't do this cross on the picture on the right. Why have I done that? Can you think why it's okay to do running on a tramp but not jumping on a mini tramp? I'm asking you to think about the pelvic floor and the core. Okay, I'll give you the answer because I did already and you have it on your slides anyway. Think of the ground reaction forces. This little girl is landing on one leg. The forces are going up her tibia, femur, across the acetabulum up to her spine, a large degree of force coming back down. But across her pelvic floor muscles, there's a much smaller force because the forces are all going down the bones. Think about this girl. There's about even pressure going down each of her legs and just as much pressure going across the muscular sling that is the pelvic floor. So it's going to be a better exercise for all our patients who have chest conditions, back pain, or maybe there'll be other factors in back pain, to do single leg ground high impact rather than double leg. So get all your cystic fibrations kiddies to jump on one leg. Here's another research project which I think is really illustrative of what we want. This is forces, intra-abdominal pressure, IAP, intra-abdominal pressure rise, with daily activities. So this researcher looked, don't worry about all the labels at the bottom, looked at all sorts of daily activities of walking, lifting, etc. And she looked at doing a crunch, a curl up. And the crossbars here are the average, and the bars give the standard deviations. So a lot of people think you should not do sit-ups when you've got a pelvic floor problem because of the pressure going down onto the pelvic floor. But if you do them well, if you tighten the lower third of the transversus, if you keep the patient doing a long spine instead of crunching down, the pressure on the pelvic floor is actually quite low. Oh, sorry. But do note that there's a wide variation, and the wide variation is people who do the action poorly. This is standing. This is the curl up or the crunch. At the other end here is cough and bearing down. So we don't want our patients to be going with their weight lifts or their jumping or their exercise, because that is pushing pressure down on the pelvic floor. It's how we tell our patients to do our exercises across all physiotherapy that helps support the pelvic floor and prevent problems like Kylie has. So go back to Kylie. She's doing this gym work twice a week. She's lifting in her shop. We can tell her so many things, what to do and what not to do, to help her reduce the risks associated with her leakage. And here's another bit of research that was done by a New Zealand physio, and you don't have to read anything of it now. I want you to look at this funny looking graph down here. Doesn't matter what all these circles are. What's interesting is there are two that are very different, one here and one here. And what are they? This is the bearing down, the Valsalva, and this one is the cough. In this other project, nothing to do with the previous one, they got the same answers. So again, it's bearing down coughing, sneezing, that are the worst things for the pelvic floor. So finally, our last slide. What implications, what decisions will you make to give Kylie the best exercise program? We have to balance the load that's on the pelvic floor and the integrity of the tissues. So we could give her some lifestyle decisions to make. Make sure she doesn't get overweight, reduce her or change the way she does her high impact exercise, reduce coughing, constipation and heavy lifting. Kylie does about 3 out of 5 of those, so we've got a lot to do with Kylie. I've put these on this side in traffic light colours. The green we can do lots about. The amber, yellow, not much, and the red we can't do anything about. So what's our big one? Pelvic floor function. But we can also train good posture, sensible physical activity. We can advise about surgery. We can't do much about neuropathy unless we teach young women who are going to have their first baby how best to push in labour, what positions are best to deliver in so that you reduce the tearing or the trauma to the pelvic floor. We could probably mention about how many children might be safe to have, but we can't really tell people you shouldn't have children. That would be awful. So we just indicate the risks. And of course, everybody gets old and the tissues decline with old age, so we can't do anything about it. So I've gone in this presentations from the anatomy, neurology, how it fit the pelvic floor fits into the core, what activities are good to do, what are not good to do, and here finally a summary slide of all the things you can do. So in your quiet time, go through this lecture again and you can see how you can go from anatomy to a pelvic floor program by knowing your musculoskeletal anatomy, your neurology and your biomechanics. Okay, so that's the end of this session and I'm sure there are some questions from online. Ben's standing up. And anybody in the room who has a question too. We'll do the online ones first.
ขอบคุณครับในห้องมีคำถามไหมครับ Okay, one question from online.
The question is, if we give diaphragmatic exercises, does that affect the pelvic floor? Yes, in a sense, it helps coordinate the breathing with the pelvic floor. Naturally sitting here or in your homes, your diaphragm rises and falls and the small amount of pressure causes the same rise and fall of the pelvic floor. You don't feel it, but as you are sitting, everything is moving inside that core. What we do in pelvic floor exercise is to try and dissociate them both so that people have some voluntary or cortical control over their diaphragm independent of their pelvic floor. So I might do an exercise where I say to my patient, take a normal breath of air in. Now on the out breath, and do this with me now, I'll do it with you. Take a normal breath of air in. Now on the out breath, tighten up your pelvic floor. Hold your pelvic floor tight, but keep your breathing going in a regular rhythm. Keep holding your pelvic floor. And now release the pelvic floor and hopefully your breathing stays the same. Now, I bet a lot of people found that difficult. And it is quite difficult because, to answer that question, yes, the pelvic floor and the diaphragm do work together all the time, and trying to separate them becomes a cortical voluntary exercise. So we can use that, and runners use it. The 100-metre sprint, those Olympians who are running the 100-metre sprint in 9 seconds, when you watch them on the TV, they hold their trunk quite rigid. They tighten all around that capsule, that pressured capsule, and their legs run like levers, and they don't breathe, and they hold their pelvic floor tight for that 100-metre sprint. So, yes, we can use this information in all sorts of different ways. At the end of the sprint, you'll notice that those runners, they don't stand up and go and chatter to everybody. They are probably leaning on the fence going, they're using their diaphragm. It's going up and down really strongly, but they can't hold their body straight. They can't hold their posture. They have to lean on something because their diaphragm is working so hard. So you asked a simple question, person online, but the answer is very complicated and has many different answers to it. But know that every one of those 4 muscles in the capsule is linked. I hope that answers your question. Anyone in the room?
Okay ครับ thank you for your answer. Okay,
No more?
not more.
Well, we are right on time for morning tea, so everybody can stand up. At home, go and make yourself a cup of tea or coffee, and we'll see you in 20 minutes.
Okay, thank you for your first section. เดี๋ยวพักเบรกนะครับพักเบรกในช่วงแรกครับจะพักถึงช่วงเวลา 11 โมงนะครับทั้งออนไซต์และออนไลน์นะครับแนะนำว่าทานเบรกมาสักนิดนึงนะเพราะว่าวันนี้เราจะพักเที่ยงกันเลทนิดนึงครับเราพักเที่ยงตอนเที่ยงครึ่งนะครับยังไงทานเบรกไว้กันหิวตอนเที่ยงนะครับโอเคงั้นเราเบรกกันก่อนนะครับเดี๋ยวเริ่มสตาร์ทในเซสชั่นที่2นะครับในช่วง 11 โมงนะครับ ฮัลโหลครับโอเคครับอย่างนั้นขออนุญาตเริ่มต้นในเซสชันช่วงต่อไปนะครับในเซสชันที่2นะครับเดี๋ยวเซสชันนี้นะครับจะเริ่มตั้งแต่ 11 โมงจนถึงเที่ยงครึ่งนะอย่างที่ได้แจ้งไปนะครับยังไงอาจจะทานข้าวเลทกันสักนิดหนึ่งนะครับโอเคครับไม่เสียเวลาอย่างนั้นขออนุญาตเริ่มเลยนะครับโอเค let's start okay
Welcome back, everybody. I hope you feel refreshed. I'm now going to talk about the pelvic floor muscles, not just through the childbearing year, but into menopause as well, or into older age. So let's take a journey through a woman's life. But I'm going to start it at the time when a woman has her first baby, looking at the pelvic floor through childbirth itself and postnatal care. When we think of Kylie, she had her problems starting after her third baby. So there must be something about childbirth that does affect the pelvic floor. And then we'll briefly look at the pelvic floor in older age at the end. Now, on your timetable, these 2 lectures between now and lunchtime are equal time, but I'm going to spend longer on this part of the next session, and less time on the examination of the pelvic floor because I think this is so important. It's the first trauma that the woman has to her pelvic floor is her first baby. In fact, jokingly, we say a woman should never have a first baby. She'd always start on her second because it's the first baby that stretches the tissues in the pelvis from a young woman to a woman who has had a baby. I'm going to start with the evidence because in the pelvic floor world, we have the highest level of evidence of so many other areas of physiotherapy. So if we look at the prenatal recommendations for prevention, we have recommendation level A, that's the top level of recommendation, that we should have a supervised and intensive strengthening antenatal program to prevent incontinence. Now, in Australia, this doesn't happen. I wonder if it happens in Thailand, that women having their first baby absolutely have supervised and intensive strengthening program. Unfortunately, it's not in Australia. For treatment, we have a recommendation of grade B, which is less but still good, that pelvic floor muscle training program in pregnancy is likely to increase the treatment effect. So if a woman has a leaking bladder in pregnancy, we can treat it. For postnatal, our recommendations are less, a grade of recommendation C, but it's if a woman has an instrumental delivery. That means she has a forceps delivery or vacuum, or delivery of a large baby, and that's over 4 kilos for the Australian body, but I'm sure it would be less for a Thai, slender woman, that it should be offered to these women for prevention. But for treatment, we have grade A recommendation that pelvic floor muscle should be offered as first-line conservative therapy to women who still have some bladder leakage 3 months after their baby is born. So if the leakage persists, then we have the highest level of evidence to say we should give them pelvic floor muscle exercises. We have lots of evidence to say that before pregnancy, any leakage is a predictor of postnatal leakage. In fact, it's a powerful predictor for up to 5 to 7 years after she's had her baby. Why the 5 to 7 years? That's just how long the follow-up was in these studies. It could be longer, but that's all we have evidence for. So 84% of women with pre-pregnancy incontinence, UI, urinary incontinence, still are incontinent postnatally, versus 30% who were dry postnatally. Therefore, those with a prenatal leak are most likely to have a postnatal leak. Really important that we pick up leakage during pregnancy because they are the women at risk. But is it just pregnancy? Is it vaginal delivery? Is it caesarean? Is there any differentiation there? Well, yes, there is. Pregnancy, we know that there's an increased risk of leakage over women who have no pregnancy. So if you never have a pregnancy, taking population studies, we're not talking about individual women here, we're talking about population data. There is a risk of incontinence over not ever being pregnant. But you add vaginal delivery and you further increase that risk. So it's both pregnancy and delivery that make a difference. And we know that having a caesarean section does not decrease the risk completely. So that increases our evidence to say that pregnancy is a risk factor. And caesarean section is going to reduce that risk, but not completely. So both are risk factors for incontinence. So do we have evidence for this? Yes, we have excellent evidence again. The evidence tells us that supervised pelvic floor muscle training of 12 weeks during the middle trimester, that's 16 to 24 weeks, is going to reduce the risk factors of incontinence. Do we make changes to the collagen? Maybe not, but bladder hypermobility may not be able to overcome either. So I'm putting this slide in from my Australian experience. I wonder if it applies to Thailand as well. We need change in Australia. I wonder if you need change here for both pre- and postnatal pelvic floor muscle training. The ICI is an acronym for the International Consultation on Incontinence, and it's the highest level of body in the world for continence research. And it gives a grade A recommendation for supervised intensive pelvic floor training, both prenatally and postnatally for those who've had forceps or vacuum and delivered a large baby. What they mean by supervised training is more than giving the patient a handout on exercises. Don't just give them something and say, go and do these exercises at home. That doesn't work. It's been shown in the research that you need to train the woman, tell her what it's about, how much to do, what's the right dosage, all of those things. So, can I ask a question? Do Thai pregnant women do pelvic floor muscle training? Is it standard? Yes? Hands up for those who think it is yes that they do it. Not many hands up. So I guess Thailand and Australia are the same. Okay. So that's prenatally. Let's think about what happens during childbirth. So there are 5 dot points here. And I'm going to illustrate that by a diagram on the next slide. So as the baby comes down through the vagina, we can get injury to the connective tissue supports by stretch. We can have vascular damage. The blood vessels that supply all the organs get compressed against the bony pelvis. We can get compression and traction, stretch, on the pelvic nerves and the muscles. We absolutely get a stretch of the pelvic floor muscles themselves, but they can do it. They're amazing muscles. And we can get direct injury to the urinary tract particularly if instruments are used, forceps in particular. So let's look at this. This is a baby's eye view of the pelvic floor. So this is what the pelvis looks like from the pelvic rim, from the abdomen, looking down into the pelvis. Here's the rectum, the vagina, the urethra. On the left-hand side, we have the muscles drawn in, and the nerves. Here's the pudendal nerve coming off S234, spreading its branches all over the muscle. Here's the sciatic nerve going down there, and this other trunk is the direct branches off S234 that goes under the muscle into the superficial muscles. When the baby's head comes into the pelvis, it takes up all the space inside the pelvis. So we're going to get the rectum pressed against the sacrum. We're going to get the urethra pressed against the pubic bone. And you can see how much stretch there is going to be on the pudendal nerves. If it's a very long labour, maybe the mother pushes for more than 1 hour or more than 2 hours, the damage will be greater because the compression of particularly the small nerves will damage those nerves, and we will have a neuropathy, a longer lasting neuropathy. Now let's look at the picture underneath. Again, it's split in half. I'll take the left side first. So here's the hip joint with the acetabulum. Here's the obturator internus on the pelvic side walls. This is the Alcock's canal where we've got the neurovascular bundle of the pudendal nerve and vessels going to the pelvic floor. Here is the levator ani, the superficial pelvic floor. This is the levator ani. Here is the fascial levels that we showed in a previous slide. Some holding the rectum, in between the organs, to the vagina and to the bladder. Now the baby's head takes up this space. So what do we see? We see a large stretch on the pelvic floor muscles. We see the rectum being squashed. We see compression against the side walls. So here's the neurovascular bundle against the ilium. And we have possibly some tearing of the fascia and the bladder being squashed at the front. Again, this is fine if it's a normal length of labour, but if we have a very long labour, then these damage may be more pervasive, more severe. On the other hand, if it's a very fast labour, the collagen fibres in the fascia don't have time to stretch in their viscoelastic way, and so we can often get tearing. So very fast or very slow labours are not good. But it's a great picture, isn't it? We as physios are interested in the pelvic floor. Stretch occurs. It's not uniform. That means that some of the muscle fibres are stretched more than the others. And the most muscle stretch occurs in the muscle fibres that are closest to the midline. And in a diagram, let's look at this in a diagram. So here is a drawing of the pubis, the pubic bone here, inferior pubic ramus on either side. Here is the urethra, the vagina, the anus. And here are some of the most medial bands of the pelvic floor. The superficial ones that just duck around the back of the vagina, and this purple one here going back around the anus called the puborectalis. So it's this puborectalis and this pubovaginalis that get the most stretch in a baby when the baby comes through. These fibres at the back are not nearly as stretched. And I'll show this in this lovely diagram. I think it's really quite cute. I think whoever designed this research project was very clever. So here is the baby's head, that blue circle, and looking at it side on and looking at obliquely. Here comes the baby onto the pelvic floor, and you can see the gradual stretch as the baby's head comes out and turns the corner and is delivered. And you can see that the biggest stretch is closest to the baby's head, these most medial fibres of puborectalis. But as I said in the previous slide, these muscles can do that. They can stretch to more than 200% of their initial fibre length. No other muscle in the body can do that. They're a really, really clever muscle. But for some women, it's not enough. And the next slide is going to show that on ultrasound. So if those of you who have never seen ultrasound pictures, I'm going to describe this. I've put here that pen and ink drawing that I showed you in the anatomy lecture, looking at from the bottom. So here is the puborectalis, that V-shaped sling, attaching to the pubic bone on each side. If we look at this on an ultrasound image, let me describe this. We have the pubic symphysis, the disc there, pubic bones on either side. Here we have the puborectalis muscle in that V shape around the anus, around the vagina, and the urethra. And that is a normal looking ultrasound image for someone who's got a nice strong pelvic floor. Look how white it is. It's dense, it's strong, it's thick. But this baby, this mother, had a baby that tore one side of the muscle. So she's got a defect, a tearing of this muscle off the bone, and this was detected 3 months after she had a vacuum delivery. What you can see is that the muscle is torn, but it means that the lovely support that the vagina has now gone on this side. So it's supported on the left, but lost that support on the right. So this could cause some maybe a possibility of a prolapse occurring later on in life because of this tearing. And this is called an avulsion, where the muscle has avulsed or torn off the bone. I want to compare this now with this ultrasound image below. Once again, we have the pubic symphysis, the pubic rami, we have the puborectalis muscle slinging around the anus, the vagina, and the urethra. I want you to compare this image of the pelvic floor with the woman in the top image. This one in the top image is white and thick and dense. It looks a strong muscle, just even on an ultrasound. You can almost see through this muscle. It is so thin. To me, it shows it has very little muscle fibre in it. Now, this woman had a bilateral defect 4 months after a normal delivery. So here we see now pubic bone, symphysis. Where is that lovely V shape? It has gone. We've got a little bit of a V there and there, but the anus is protruding. We can't even see if there's anything holding up the vagina, and the urethra is still in place. So that is a quite severe, large defect on both sides. And what it means is that there's a large space in the middle of the pelvic floor muscle that can act as a hole for organs to drop down into. So this woman would be at a high risk of getting a prolapse later on in life, even if she doesn't get it postnatally. So why am I spending time on this slide? It's to encourage you to please make sure your ladies who are pregnant get some pelvic floor exercises to have decent pelvic floor muscles to go into childbirth, so that even if they have an instrumental delivery, they may only have a small trauma to their pelvic floor, unlike a weak pelvic floor, which is much more at risk of having damage to it. So that's my plea. Pelvic floor muscle training during pregnancy, please. So as physios, we like to deal with muscle, as I said. But we don't know a lot about avulsions. Can the puborectalis be rehabilitated? Well, unfortunately, the first published study showed no difference between those who were rehabilitated and those who weren't. That's awful, isn't it? That means that the muscle is unable to be rehabilitated. So that should tell us that we really do not want that to happen to our pregnant women. We need to take much more care of them, maybe reduce we as physios can't do anything about this, but reduce the number of forceps deliveries. Make sure that women deliver in positions that are not going to tear their muscles, that they're not in stirrups, or that they can move around in labour, that they're well prepared. There's a whole lot of things we can do which are out of the scope of today's talks. But I wanted to point out that Kylie, for instance, with her fast labour and her large baby, maybe something happened in that birth that has made her pelvic floor muscles feel different, and she's having trouble now at age 36. So we have a responsibility to our patients to prepare them for childbirth. I'm putting this picture up, this graph up again, just to remind you that there are well-documented risks. So we need to, as clinicians, reduce the risks. We have a duty of care. Okay, so we're still in childbirth. In childbirth, the muscles can tear off the pubic bone at the front, but during the birth process, actually at the time that the baby's head is passing through the pelvic floor, it might be noted by the obstetrician or midwife that the pelvic floor muscle just is not going to stretch. And so the answer to that is to do a cut, an episiotomy into the muscle. But if that opportunity is missed, the woman may tear the muscle, and the usual way the tear goes is posterior towards the anus. And if it goes to the anus or through the anus, it's called a third or a fourth degree perineal laceration or a tear. This is not good because particularly a fourth degree tear goes through the mucosa of the anus. It requires a lot of stitching, and we have some very skilled obstetricians and midwives who know to repair this in theatre, and that's fine. But there may well be a deficit, particularly with these fourth degree tears that go into the anus. If it's a third degree tear, the tear goes backwards from the vagina just as far as the circular muscle around the anus and goes into that skeletal muscle, but doesn't actually go through into the canal of the anus. So there is a big difference between a third and a fourth degree tear. For women who say, oh, I had a second degree tear, I had a tear, the tear is a very nasty word. I don't know what word it is in Thai, but there is probably an equivalent that is a very scary word, and we don't want to use that too much. But better, we don't want it to happen at all. So what would be the symptoms after perineal trauma? What will a woman tell you about if she comes to see you? Incontinence, leakage. Not just urinary, but anal incontinence, leakage of flatus, wind, or solid. Or they may have a lack of sensation of wanting to pass a bowel motion, or as they are passing it, to not feel whether they've finished or not. So it's quite disabling emotionally. Of course, they've probably got a lot of pain in the area because the obstetrician has had to do quite a bit of surgery to get the area sewn back. And often they have the biggest symptom that they tell you as a physio is dyspareunia or painful sex. And of course, that then leads into psychological issues, partnership, intimacy, and grief in particular. So many women would tell you, my body just isn't mine. I don't know what's happened, but it's different. So they are suffering grief about the loss of who they are, particularly their sexual being. So we need, as physios, to know how to recover from this. So I've got a bit of a few good slides here. we have to go back to basic science and understand trauma and the process of inflammation. Physios all know this very well. We know that trauma produces inflammation. Any torn lateral, collateral ligament of the knee or medial ligament of the ankle will tell you. So we have a vascular response first, right at the beginning. We get the swelling coming up, and then we get the cellular response to limit infection in the next 24 hours, 48 hours, I mean. So, as a physio working in a maternity hospital or anyone, a midwife, anyone, observe the perineum, take the pad off and look at the skin and minimise the edema, minimise the swelling by rest, ice, compression, elevation. You all know that from every sporting injury ever. It's the same with the pelvic floor. Do not change, just do it. Need to immobilise to protect the new blood vessels growing into the traumatised area. But we also need to limit the inflammatory response, limit fibrosis, possibly by giving non-steroidal anti-inflammatories. And there's a bit of discussion around when that should be, maybe from day 2, day 3, or painkillers, so that the woman can have the ability to rest. Compression. Now, how are you going to apply compression to the pelvic floor? A lot of women think they need to let their pelvis go free after they've had a baby, but no. Get them to put on some firm underpants. Put a pad or maybe 2 pads on. They'll have a pad on anyway, but to wear firm underwear to push up against the perineum so that you limit the amount of swelling in the perineum. And every physio has probably seen a diagram like this over your time, looking at muscle fibres growing across a tear. How do we encourage satellite cells and myoblasts to enter into the traumatised area and find the myotubes to begin to grow towards each other across the breach? Now, the doctor will have done some sewing, so the ends of the myotubes should be close together. How do we make the muscle stimulate the cells to grow? Gentle exercise. Now, we always know that gentle exercises encourages some muscle repair. Same in the pelvic floor. We know that muscle regeneration peaks 5 to 10 days after injury, so we need to do this sort of work in the first 5 days. The mum is really new at this. She's breastfeeding a baby, she's tired, she's got all the visitors. How are we going to encourage her to look after her pelvic floor? Because we don't want her to wait till later. Fibrosis begins within 2 weeks, and it's going to interfere with muscle regeneration. So we have a choice as clinicians to prevent fibrosis or allow fibrosis, but the outcomes are different. So I'm going to suggest to you that get maximum muscle regeneration, and these are in the first days when the woman has gone home from hospital. She needs to minimise her immobilisation, so she needs to get up and start moving again. She was resting in hospital, now she needs to move. But with low forces, don't do anything fast. Don't lift up your toddlers or anything. Be gentle. Do a slow loading. Lift gently and slowly. And make sure that it's pain-free activation. So when you give the woman some pelvic floor exercises, it's gentle. It's within limits of pain. It's not, do your exercises, go to the gym. It's quiet, slow loading, low forces. Now, the next few slides are going to take you to Australia. AFL is the Australian Football League. And here's a footballer kicking with tremendous force. One of the biggest injuries in Australian rules football is hamstrings tears. So I'm going to compare the footballer's hamstring tear with a perineal tear of a pregnant woman. In the AFL, muscle recovery equals dollars, dollars, dollars. We need our best footballers back on the field. So they want the greatest muscle recovery in the shortest possible time. So what does a hamstrings tear happen in they get their tears graded? Well, same as with the perineal tears. There's no break in the skin, but with the woman, the tear occurs through the skin. If it's a complete tear, surgery is considered. It's not mandatory, it doesn't always happen, but in women with a complete tear, surgery always happens. It's automatic because you've got skin tear and in an area where moisture comes over the skin. It absolutely has to be. In the AFL, we have strong adherence to rest, ice compression, elevation, and then gentle mobilisation, partial weight bearing, on crutches, etc. What do? We send in obstetrics, we send our woman home, tell them, yes, put some ice on if you feel pain. And then when they get home, nobody tells them what they can do or can't do unless you've got a good physio. Then the hamstrings tear person gets aggressive rehab and all the way through. Well, the woman's home. Who's looking after her? She may have a pamphlet and she does non-aggressive rehab, commonly self-management, and self-doses her pelvic floor muscle training. In the AFL, we know previous injury is a risk factor for recurrence. In obstetrics, we know previous injury is a risk factor for recurrence. But do we do much about it? Possibly not. So you all know this from your physio, but the one thing I do want to say is a hamstrings tear in a football player, the return to sport is not for 6 to 12 months after any surgical repair. Let's compare that to the postnatal woman. We're asking her to return to full function about 6 weeks after a surgical repair. She goes back to her obstetrician or her doctor at 6 weeks to have the final sign off, and that's it. Bye-bye. So it's very different, and yet it is the same sort of injury. So in Australia, I think we do our women a disservice. I don't know what it's like in Thailand, but I'm presenting you with the Australian story so that if anything it's like that in Thailand, it's up to us as clinicians to advocate for better service for our women. I leave that one with you. So, in summary, what's the ideal program for our pregnant ladies or our postnatal women? For the first 2 to 3 days, rest, ice compression, elevation. Not just one ice pack when they come out of labour ward. No, ice every 2 to 4 hours. Then after that, up to 7 days, gentle pelvic floor muscle exercises within limits of pain. And then up to 6 weeks, gradually increase the exercise dosage. And then after 6 weeks, refer on to a physio. I hope the doctor talk to your obstetricians to continue your training program until the results are achieved. So as physios, we work really closely with obstetricians and gynecologists, and particularly at maternity hospitals. We are the people who take the woman from the hospital into the community, and I think we have to work in a really strong team environment to get women really well rehabbed. What's the alternative? And this is where I know I'm going to talk from the Australian experience. In Australia, the maternity hospitals are focused on delivering the babies, moving the patients out because the next one's coming. They're very busy places. And you, as a physio, talk to the administrators and say, yes, but these women will have problems down in 10 years, 15 years' time. Don't want to hear about that because it's not our business. That's the gynecologist. That's another whole story. And so you don't get very far. Well, that was my... I'm telling tales out of school now. I was the head physio at the Royal Women's Hospital in Melbourne for 10 years, and I tried and tried to get rehab outside the hospital into the community, but the hospital administrators weren't interested. No, it's not our business. But as a clinician, it is our business. So I think we do... there's a bit of political talk here, but I think it's important. All right. So physios, what can we offer in the postnatal period? I think the problem is a very short window of opportunity. The women are in hospital for a very short time. They're tired, got a new babe, they've got visitors. Maybe they have one postnatal class in the hospital, but that's all. A physio in Melbourne did a research study looking at the timing of pelvic floor information, whether it was 3 days after the birth or 6 weeks after. And she found that women could comprehend and retain the information equally, but they were much more compliant. They did their exercises better if they learnt them in the class setting in hospital. So I tell you this to make sure that if you are working or you're talking to your colleagues who work into a hospital, make sure that you are getting the women to learn to do their pelvic floor exercises in hospital before they go home. Now, in Australia, there's always poor attendance. Women don't come, oh, I'm breastfeeding, I want to have a shower, I've got a visitor, the doctor's coming in 10 minutes. All sorts of reasons they don't come. If you have any strategies in Thailand to overcome that, I'm very happy to hear them, because I've run out of things to do. Anyway, I leave that one with you. So, in conclusion, what to do? Look at the perineum if you're in the hospital, just to make sure that it's okay to do pelvic floor exercises. Make sure there's not too much bruising or swelling. Make sure you look at the pelvic floor moving so you can see that the patient can actually do the correct contraction. As a pelvic floor physio, you don't do an internal examination, or if the doctors won't either, until it's 6 weeks after the baby's been born. Understand that just giving the patient a handout, a pamphlet, is not good enough. We need to teach correct pelvic floor and abdominal bracing for going home and for their activities of daily living, and their posture too. So, as a physio, we must remember that we are part of a team, and make sure that we refer back to the doctors if there's something unusual or severe, or the patient's not recovering well, because there may be further surgery required. And the doctor will make the decision whether to do surgery then or later, or after the woman has finished having her children. In the meantime, we can talk to our patients about whether they should have a caesarean section for the next baby. And in Australia, it's becoming very, very common for women never to have another vaginal delivery if they have problems with their pelvic floor, to always have a caesarean section for the next birth. I don't know what it's like here in Thailand, but I'll just give you that for what Australia is doing. So, take a deep breath. That's childbirth. We are now going to move to the pelvic floor in old age. So, look at this graph. This is a graph of muscle mass over a lifetime. Could be any muscle, quads, deltoid. What it says, we've got age on the horizontal axis, increasing age, and muscle mass on the Y or vertical axis. Along here we have a disability threshold, the solid orange line, and higher up a frailty threshold. So muscles can become so weak that they bring on the geriatric syndrome of frailty. So what does this graph tell us? In early life, we get growth and development up to a maximum peak. In adult life, we maintain that peak. But look, now that we've got our, we're grown, there's already a difference starting between those who've maintained maximum muscle mass and those who haven't. In older life, we don't regenerate as much, but we can maintain our muscle mass with exercise. And there's a large difference between the lowest and the highest level of function and level of muscle mass between elderly patients. If we have a high muscle mass, we're going to be above both the disability and the frailty thresholds. Well, this is pretty obvious to us as physios, isn't it? Get people exercising all the way through their life. And if we're talking particularly about the pelvic floor muscles today, exercise the pelvic floor muscles all your life. Now, the pelvic floor muscles in particular follow the same graph. Age on the x-axis, pelvic floor muscle on the right. We have a gradual decline and we have a symptom threshold. We might have some predisposing factors of how high their top muscle mass, or peak muscle mass is, but in adult life we have some inciting factors. That means something that happens to the pelvic floor. And how good is the recovery after that? We've just been talking about childbirth, so let's make this childbirth. During childbirth, pelvic floor function goes down, but with good rehab, it comes back up again. And more children, menopause, frailty, you're going to get symptoms. And most women over about 70 would have some symptoms. So this means when we are talking about curing incontinence or getting the pelvic floor to maximum in older age, we may not be able to. It may be too late. So this is a diagram that's come from the International Consultation of Incontinence again. Ideally, everybody in the whole world should be independent. They should be dry and not dependent on ongoing treatments or pads or people to help them. That's fine when you're young. It just doesn't happen when you're older. So success when you're dealing with older people is going to be dependent continence or contained continence. Failure is that the patient is incontinent and unable to go out, their whole life changes. They become housebound, depressed, etc. So we don't want that. What does dependent continence mean? It means that they can stay dry if someone takes them to the toilet, or if they're doing pelvic floor exercises and they're on the right medications. They can still be dry. They can still live the life that they want to live. Also, success is what we call contained or social continence. That means that the urine is contained with pads and they can get to the toilet with appliances, or they've got leg bags, they've got catheters, that they can go out because the urine is contained by a catheter or a pad or something that keeps them dry. So if you're dealing with older patients, keep this in mind and don't go for, I can only give you pelvic floor exercises, and if you can't do those, you'll have to be wet. That's horrible. So we go for dependent or contained continence. We've got gravity to fight against. It's great gravity. It keeps us all attached to the planet. But as our overall muscles weaken, our skeleton shrinks down with gravity. So as we get older, the distance between our rib cage and our pelvis becomes shorter, so our abdominal muscles can't work the way they used to. And these are large muscles that are important in our cylinder with our diaphragm and our pelvic floor. So if the big abdominals are not working correctly, it means that probably other muscles aren't working as well. And with the larger slope of the ribs and the lower rib cage and the shorter distance between pelvis and rib cage, the diaphragm is probably not working well because the patient has to lift their ribs up much higher every time they breathe in. There is not the erect posture of the young woman. We've got flexion at the hips, and we've got a large kyphosis of the thoracic spine and probably lordosis of the lumbar spine. Everything mechanically is against that older woman being continent, just the mechanics of her trunk. So we are going to go for social continence or dependent continence. But we're also going to look beyond the bladder. What changes do we have going on through the whole body? There are structural changes. We have changes in collagen. It's not as strong. In men, we have an enlarged prostate, so there's going to be more difficulty getting urine out. We've got lower blood flow, perfusion of the whole pelvic organs. We've got decreased hormones, estrogen, antidiuretic hormone from the kidneys at night. The bladder functions differently. We've got a reduced capacity, doesn't hold as much, less sensation, which gives us a lower flow rate and not so much good closure pressure. The urethra isn't as tightly closed. And we've got increased, therefore, residual urine. That means the woman or man does not empty their bladder completely every time they go to the toilet. There are more infections in the bladder. If there's got some bladder staying in the urine, it develops infections. And the detrusor muscle is not as well, it acts oddly, so that the neural control is worse, and so it can contract at odd times, making you feel like you want to go to the toilet. You've also got loss of skills. Getting to the toilet is slower. Maybe there's a rug in the way, and so people can wet themselves on the way to the toilet. They might have too many buttons or something to tie to take their pants down before they get onto the toilet. Their vision is poor. They can't see the toilet seat properly. So there's just plain sensory things, loss of skills. Then we have dementia and depression. All the multiple comorbidities, the arthritis, any other neurological disorder, for which they may be taking multiple drugs, and the interaction between the drugs and incontinence. So there's a lot to think about when you are dealing with leakage in an older person. And the other thing is, older people lose their friends, they die. They're often on their own, their partner has died, their children live overseas, and so their social supports are often fragile. And if just something happens, then it's often shown in the bladder. It's a very sensitive organ. So the problem for leakage is often related to conditions that are outside the bladder and the bowel. So could we change what we do? Instead of just going for pelvic floor muscle training or bladder training, could we look at other things? And yes, we could. We could prevent incontinence by looking at evidence that we have in healthy elderly. And there's been lots of research in this area, some very good research too, might I say. We know that functional impairment predicts incontinence later in life. What should we do? Keep our old people active. So reduce impairments in the young old. Encourage an active lifestyle. A lot of people themselves think, oh, I'm old, I can't do that. Yeah, no, not me. But we should encourage them. And what should we encourage mostly? Lower limb mobility, lower limb strength, walking, going up and down stairs, sit to stand, things that you would do in rehab for all your patients. But now you know that it's very good for their pelvic floor as well. So what are effective interventions then? We certainly know that pelvic floor muscle training is better than lifestyle interventions, and we should tell our older people that pelvic floor muscle training should be done all the way through their lives. And that was my PhD study. I did it in older people, you see, so that's why I'm really keen on everybody looking after old people. But what about the frail elderly? Again, we've got this strong association between functional improvement and improved continence. So you see, it's outside the bladder. It's something different. So it's lower leg strength and mobility again. So in older people, we can't just get them to do squats and sit to stands, but we can provide them with gait aids, a walking frame, put rails along the wall towards the toilet, lower the bed, all sorts of things that help people become mobile in older age. But over and above all of that, before we get to that stage, we know that walking speed, walking balance and stepping patterns are independently associated with urge incontinence. That's the neural side of things. They're going up to the brain. So let's think about doing mobility training, balance training, etc. And so these interventions are going to help not just stress incontinence, but urge incontinence as well. And we know from another research study that walking training can reduce nocturia. So instead of having our older patients sit for most of the day, we need to encourage them to keep walking and keep walking at a pace that is keeping their muscles strong and their reflexes working well. Because there's been some other fabulous research done about this with incontinence in the brain. A physio in Canada was looking at executive function. That means decision-making in our frontal cortex and divided attention. So someone says, an older person is going to the toilet and someone talks to them and they lose concentration on what they're doing. Their attention is taken away from their job, what they're doing, going to the toilet, and they leak. So we are often, as physios, telling our patients, tighten your pelvic floor on the way to the toilet so you don't leak. But maybe they can't do that. Maybe that's the problem, divided attention. They have to do two tasks at once. So what these researchers did was treat the pelvic floor muscle, or teach them muscle training with a virtual reality game. And so this physio had the music going, and she was getting them to do steps in all directions, and not think about their pelvic floor, not think about leakage, but just to do steps. And the music was going, and the dance steps were up on the screen. And she found a major improvement in their continence. The results were effective to reduce the symptoms, increase their quality of life, and it improved their cognitive ability too. Not just their bladder, it was their brain as well. And they improved their muscle strength. She did not do a formal pelvic floor exercise at all. It was all dancing. But it also then improved their adherence to exercise training as well. So interesting, isn't it? Now, so anybody here in the room who is a physio in a rehab centre or with older people, please think outside the bladder. do what we understand our training is for older people, for rehab in general, and you're going to get results. But let's just take my last slide. This was a systematic review of 4 different studies about treatment of incontinence in older and frail older people. And what they were looking at was pelvic floor muscle training still effective in these old people? Despite what we've been talking about, dance and walking and everything else, just doing the exercises, was that actually effective? And I don't know whether you are good at looking at forest plots. This is what's called a forest plot. And anything on the right of the vertical axis means it was effective. Anything on the left, not effective. And so all these 4 studies showed effectiveness in older people. So I'm giving you the evidence to say, sure, change your view when you're treating older people, but don't neglect the isolated muscle training as well. It works. It's been shown to work. And that's the end of that talk. So that was it. Once again, I'd like you to stand up, take a breath, talk to the person next to you. At home, go and talk to the dog. So this lecture, now have you all taken a deep breath, ready to go again? This last half hour before we have a lunch break, I'm going to tell you about physical assessment of the pelvic floor, but we're not going to do any of this in today's session. It's really just for information, which is why it's a short lecture, but it gives you an idea of where physios who do this sort of work, what physios who do this sort of work actually do when they're confronted with a patient. Firstly, I want you to look at this picture on the front page. Have you any idea what it is? I'll tell you. It's an art installation in one of the art galleries in Australia. It's actually in Hobart, the capital of the island state, in the southern part of Australia. And it is called the Great Wall of Vagina. It's not vaginas, but it is vulvas. And I want you to look at it because if you did do this sort of work, probably the only surface anatomy that you have seen is your own. And yet the anatomy of the perineum is as different as all the different facial features in the world. So I show this picture to my students and get them to have a good look, because it would be awful if you pulled back the robe and went, oh! Because it was so different. And it's a part of the body that is very private. So it's not anything that you would see unless you are in a clinical situation. So that's what the picture is. But interesting that it's an art installation in an art gallery. Okay. So if you're going to do an intimate examination, a vaginal examination on a woman, it's not something you can just go and do. You need some training. First of all, of how to get informed consent and really give the woman choice whether she goes ahead with it or not. Both you and the patient have to be psychologically ready and aware of what is going to happen. You as the physiotherapist, because you are going inside another person's body. the patient because someone is invading their body. And it could be an invasion if the patient isn't ready for it. So it's one of the most important things I cannot stress enough. You must get informed consent. You wouldn't do this unless the process is going to give information to the patient and also to be therapeutic. Of course, you as the therapist have to be capable. You can't just do it willy-nilly. It's not something, it's too important. But if you are not ever going to do this sort of work, but you have, the patient is in your rooms, you can assess by talking to the patient, asking them about what they can feel. You could do an external assessment. You could leave their pants on and put your hand, with their consent of course, over their perineum and feel movement under your fingers. Or they could take their pants off and you could see their perineum and look at the movement of the pelvic floor as they do an exercise. Or if you ask them to do a cough, can you see a prolapse coming down? Now, normally you assess a patient on a plinth with their knees bent up in a crook-lying position. But if that was too confronting for a patient, you could change the position to, be a side-lying position, or that's about the only other position I can think of, actually. You could change the standard examination method, and maybe the patient is very sensitive about latex, so use non-latex gloves. Maybe they're sensitive to some lubricants. They might bring their own hypoallergenic lubricant with them. Or we can use ultrasound. And after lunch, I'll be doing an ultrasound session with you. Remember this slide about what the surface anatomy is. I don't need to spend any more time on it, I don't think. Remember, we've got the, the laser pointer. We've got the vulva here, the labia pulled back, clitoris at the front, urethra, vaginal opening, perineum, and anus at the back. Under the skin, we've seen this diagram in different forms earlier today. The superficial muscles that surround just the vagina and urethra, and the anal muscles that encircle the anus. So what does a digital examination or intimate exam look like? Here's a diagram. So the clinician puts a gloved finger into the vaginal entrance, and in this diagram they're looking at the superficial muscles that surround the vaginal entrance. So the finger is only going in a short way and examining those muscles. To get to the pelvic floor muscles, we look at the next slide. The finger goes in deeper to feel these muscles, about 1/3 of the distance through up the length of the vagina, and the finger will palpate the iliococcygeus or coccygeus and puborectalis. You may even be able to palpate over to obturator internus and up to the the ischial spine. So you're going to get a good idea of where the organs are and what the muscle's doing. So here's a list of the palpable structures that are not the pelvic floor muscles that I would palpate when I do a digital examination. I don't need to go through them, they're just there for information. Would you do a vaginal examination on everybody? Well, for those who have poor sensations, maybe you will want to do one to test the sensation, or maybe you think, I shouldn't do an examination. But let's suggest that if the subjective history suggests a sacral nerve injury, or maybe an upper or lower motor neuron disorder, or obstetric or surgical trauma, where the woman says, I can't feel it, or I would need to go to the toilet all the time. So you'll think, a nerve you'll suspect a nerve trauma. Or it's prior to any application of electrophysical agents, such as ice or heat or electrical stims. You will want to know if the patient can feel what you are going to do to them. Just note that you don't require sensory testing if you've got pressure manometry or EMG. It's just when you're putting into the body stims or heat or ice. Once again, I'm not going to spend time on this, but just where to test. Obviously, S234 is your dermatomes. You'll do light touch and sharp and blunt. Do you need to do temperature? I don't think so. But here we go, is S5 is just around the anus. S4, a touch just around a wider circle around the anus. S3 into the groin, into the upper leg, and S2 over the adductor longus in the thigh. Oh, here's a close-up. So that's there for reference. And here's for reference how to do it. Just one test each of light touch. Use a cotton ball or a tissue, or buy neurotips. They're the preferred option. I don't know whether they're available in Thailand, but if they are, they're the preferred option. And if you do temperature, it's got to be properly standardised. Not just put a spoon under the hot tap and do warm and cold. That's not standardised. So that's why I tend not to do temperature. It's too tricky. Just do light touch and sharp blunt. Now, you're going to do this intimate examination. And I've said you need to do informed consent. You need to get the patient on board. I'm not saying you should persuade them, but when you are telling them and educating them on why you are going to do this, you need to give them a good explanation so they feel, yes, this is going to be helpful to me. I'm going to improve my rehab by allowing the therapist to do this assessment. So use precise language. This is an Australian expression. Verbal diarrhoea means you talk, and the patient is lost. What did she say? So precise sentences allow time for the patient's brain to catch up to what you are saying. Make sure that you link your history taking and what you're going to do with the objective assessment, what you're going to do with this examination. Why are you doing this? Well, I found that you're leaking when you jump, and you're wearing a pad and you're only 36. It would be really good for me to get a better understanding of your pelvic floor if I could do this examination, something like that. Don't assume they've got knowledge. Some women have no idea about that part of the body. There's something they don't like to think about. So have a pelvis, a model, have some diagrams, and encourage the patient to touch and point to different things on the diagram or on the model. And give the patient confidence in you. Don't be nervous about this. Tell them that you're a clinician, you've been trained in this. I've been doing this for 1 year, 5 years, 10 years. Encourage their confidence in you. That's your verbal language. But what about your non-verbal language? And what about the patient's non-verbal language? Patient may say, yes, go ahead with this assessment. And then you lie them on the bed and they've taken their clothes off, you've draped them modestly. And then the patient lies there with their hands behind their head, looking away. That is non-consent. And I would be very, very cautious to do an intimate examination if someone was looking at the ceiling, or they had their hands behind their head, or they're arching their back, or they're closing their eyes, or their breathing goes shallow. that is all non-consent. That is non-verbal non-consent. So don't just listen to the words, look at their body. So, could you overcome this? Yes, you can give verbal reassurance. You can give sincere eye contact. Don't eyeball them and stare at them, but genuinely, sincerely say, look at me, I'll help you, this book, I'll guide you through this. And say, give me feedback. Tell me how you're feeling. This will be a gentle examination. And there's plenty more things that you can do along those lines to make sure that the patient is on board, is going to participate, that this is not the clinician doing this to me. This is together, the physio and me, we're learning more about how I can fix my problem. It is so important. I can't stress it enough, because we as physios normally do things outside the body. This is probably one of the few areas of physio where you are entering another person's body. So what are the essential elements of consent? Education. What's the nature of what am I going to do? What are the risks? What are the benefits? What are the alternatives? Are there any uncertainties? Are you happy with all you understand, or are you still uncertain? You need to assess the patient's understanding, not just say, do you understand? But tell me what you think I'm going to be doing. And ask the patient to say whether they would want the intimate examination, prefer ultrasound, prefer you just to look. Get the patient to state their preference. I always want to hear the patient say yes, if it's an easy yes, or I would like to this. So I know I'm labouring the point here, but it's pretty important, because we could be sued for assault if the patient thinks that you have just gone and done this thing to them. So I always make sure I get consent when I'm at the desk, when I'm talking to the patient, before moving to the examination couch. Because that way, we're both sitting, we're head to head, not the patient lying down and me standing up, because that's a power position. Make sure you're both upright. And remember that even though you're talking about the risks, they are minimal compared to other interventions that the patient might have. So I'm saying you must mention the risks, but don't overemphasise them, because they really are minimal. So don't scare the patient, and let the patient feel she's in safe hands. Now, I've got experience in doing this. I will be doing this. You can say no. I always say to the patient, you can say no at any time. Just make sure that you let me know how it's going all the way through. Keep your language short and use a 14-year-old's vocabulary. Don't expect that they understand the language that you, as a university-trained professional, understands. Have the patient state in their own words, and for some institutions, some hospitals, they actually ask the patient to sign. I personally don't. I think that's a bit confronting, but some people do, and that's absolutely fine. You do what you need to do in your institution. Are there any contraindications? Well, yes, there are. Big one is no consent. If they're not psychologically ready, if it's a child, if it's an early stage pregnancy, if there's non-menstrual vaginal bleeding, say postmenopausal, there may be something more sinister going on. If there's infection, open wounds, broken skin, lack of sensation, there's lots of reasons why you would not do a vaginal examination. But there are some that are just precautions. You might just be that they're unsuitable, or they decline the internal examination. It might be that they are more than 12 weeks pregnant, but there's been a bit of spotting and bleeding through the first trimester, and so it might be an unstable pregnancy. I would still do a an internal examination if the woman is menstruating, as long as she feels comfortable. It's not a contraindication to how the muscle works or anything. If they've got an allergy to gel or gloves, or they are sexually inactive, have an infection, or they've got a lot of pain or have had sexual abuse, these are not, they're only precautions. You don't need to think of them as contraindications. They may be, but they need not be. So that's a lot about intimate examinations, and this is my last slide before lunch, and we've got time for questions. And I said this would be a short one because I don't want to go into the actual how to do it. This is not, it's more the fact that if you were thinking that this would be a pathway for you to go down to make sure that the preparation is full and complete and you feel confident in what you're about to embark on. So thank you for listening, and I'm going to hand back to Ben and see if there are any questions.
ในออนไซต์มีคำถามไหมครับโอเคทางออนไลน์ไม่มีคำถามนะครับมีไหมโอเค
No questions.
No question.
Any questions from in the room? Who in online or in the room does pelvic floor examinations now? Are there any continence or women's health physios or doctors who are doing this? No? Okay. So do you feel that last 20 minutes or so was a bit over the top, like, I'll never do it? Or do you feel that you could embark on this assessment process if you learned how to do it successfully? I hope you would. I don't want to be so negative that you wouldn't go ahead and do this sort of work. I just want to set up the parameters that it is important that you really listen to your patients. Okay?
Okay.
A question?
What do you recommend about the grading of the internal functional examination, like Laycock or scale or something?
How do you measure the muscle? Yes. I'm going to go into this more this afternoon, but when you are doing an internal examination and you're asking the patient to squeeze and exercise the muscle around your palpating finger, it's not just can the patient tighten or not, are they doing it correctly or not. As in any muscle examination, you would grade the muscle. And we use the modified, the Oxford scale, but modified for the pelvic floor. So the modified Oxford scale. And also from the ICI, we have another scale as well. But I'll talk about that this afternoon. Okay. Well, take a break, everybody. We'll return at 1 o'clock. Is that right?
1.5
Oh, 1:30. We've got a whole hour. Well, you can have a really good rest.
Okay, thank you for your presentation. โอเคครับเดี๋ยวพักเที่ยงนะครับเดี๋ยวเราจะเบรกกันตอนเที่ยงครึ่งนะครับเริ่มเซสชั่นช่วงบ่ายตอนบ่ายโมงครึ่งนะครับโอเคครับทางด้านออนไซต์นะครับมีอาหารไว้ให้แล้วนะครับเชิญรับอาหารทางด้านนอกได้เลยนะครับแล้วก็ทางออนไลน์นะครับเดี๋ยวเราเจอกันอีกทีตอนบ่ายโมงครึ่งนะครับขอบคุณมากครับ